Dr. Stone is logging in now.
Thank you, Erin.
And Kelly, once your members pop on, you may want to introduce yourself again, just so they make sure. My other meeting's starting. I'll be right back.
Thanks, Erin. Okay, I believe I just got an email from Lisa stating that she could not get in. So let me see if I can send her a new link.
Hi guys, it's Lisa. I don't know about you all, but I had a real struggle getting in here.
I'm sorry to hear that. I don't, it worked for me. Lisa, I'm Kelly Sheets.
Hi.
Hi. I am working with Erin, kind of tag teaming today. She had another meeting starting today at 3 o'clock. So I'm starting the meeting for her. It looks like we only have you and Eva Stone on as members.
Oh.
It is 3:06, so we do not have a quorum.
Hi, everybody.
Hi.
And I will also be your main contact. Let me turn my video on for just a short minute. Okay, so hi. So I will also be your main contact when Erin goes on maternity leave in March.
Okay.
So I will drop my email address in the chat in case you don't have it. And there you go.
Thank you.
Okay, it looks like Jennifer Wiseman is entering now, so that would make a quorum.
Hey, Jennifer. Okay, well, sorry for all the delays, and welcome everyone. Thank you for joining us. And Kelly, thank you very, very much. Yeah, I was, you'll see those of you, you won't see it, Kelly, but Eva will, and Jennifer, I was like, I can't get in. I'm looking. Anyway, I'm here, but I can't get in.
Technology is such a treat sometimes.
Oh gosh, I mean, it could be my computer, but anyway, welcome. Happy December. Holidays are here. I'm sure everybody's crazy busy. We'll get moving here. We'll go ahead and call ourselves to order. And we'll start off with approval of our minutes from October. So have you all had a chance to proof the minutes from October?
Yes, for me,
Okay,
and I so move that we approve them.
thank you. Jennifer, have you had a chance to take a look at them?
Yes. Do you need me a
Perfect.
second?
Yes, ma'am, that'd be wonderful.
Sure, I'll second.
Perfect. Thank you so much. Okay, with that, we'll go ahead and move on. And most of this, I believe, Dr. Stone, are items that you wanted to follow up on.
I think the first one, Lisa, is the presentation to MAC about this.
Oh, to presentation.
Mhm. And you don't want me speaking to that because I'm I'm completely out of the loop on that.
The presentation to the MAC, what we did was we brought the two questions back to the MAC. Where are we in regards to the questions that we had brought forward for reimbursement for midwives and reimbursement for APRNs. And I just got, and where is it? From Aaron. This about the data requests and the presentation. I can read it to you verbatim. I'm sorry, I'm multitasking today. I'm doing someone else's job too. That's the rates explanation. Well, darn it, I feel so ill prepared. I'm so sorry. Basically, I didn't really get an answer from the MAC. In regards to the first part, they have chosen to pass it this time. And in regards to the second part, they're going to come back to us with an answer. And the first part is the midwives, and the second part is the APRN reimbursement. And it was very brief. There really wasn't a presentation.
How does that work, Lisa? For the MAC to get back, does that come just in the form like of the emails that we get, a response that way?
No, they you wait till the next meeting
Okay.
and listen through.
Okay.
in their old business, and they come back with requests, answers to requests that you've made.
Okay. Do you want me to go ahead, Lisa?
Yeah, and then there was a lot of data pending request items. And most of the requests had come from Dr. Stone and Dee Polito. And really, I am not the expert to be asked to be speaking to that. That's really your all's umbrella area of expertise and your questions and things that you brought forward. So I am wanting to turn it over to you at this point.
I'm sorry, can I?
Oh,
have
April's
just a
here.
second?
Hi, April. April Hester's on, Kelly, just to make note.
Hey,
Okay.
everybody. I just
Hi.
wanted to
Hi.
say hello. I've got my camera off. I'm in a patient care area and I don't want to violate HIPAA, but I am here and I am listening.
That's wonderful. It's so good to have you on.
Regarding that, I'm sorry to interrupt, but we do need to go back to the minutes. We can't actually approve those without the voting members being on camera. So, Jen, if you could turn your camera on and then go back to vote on the approval of the minutes, then we would have that for the record. Thank you.
I can hide in the bathroom.
Okay, so if you just want to do that whole minutes portion over again, we'll have that for the record. Thank you so much.
You're welcome. I make a motion to approve the minutes. Oh.
And I'll second it. And we're all in favor, right?
We're all in favor then.
So we're good on that?
I think we're good there.
We are, yes. You're welcome to move forward. Thank you. And I apologize for having to make that interruption.
No, it's fine. That's fine. We want to do it right.
Keep us in line.
Yep.
That's right. Well, the next item we talked about was just the rate setting. I think we've gotten an email that talks a little bit about the rate setting for.
We did.
Yes, and so Lisa, you had asked if we needed to have any more discussion about that.
And I didn't know if we did. I mean, does this explain everything you needed or?
Yeah, it explains the process, I think.
Okay.
And then I think there'll just be some additional questions under new business about that.
Okay, all right.
And then the other bullets under old business are part of what we had on our data request. And I see we've gotten some of those today. And then Aaron says that we will get, once the data request has been reviewed, I guess the additional that she'll get it to us. So we should be, so I haven't looked at the information we got today, but I think once we go through that, we'll just see if there's any that we haven't gotten yet. So thank you. I don't guess Aaron's on here, but thank you. Aaron, if you can convey that, Kelly, for getting.
I will, and Erin should be joining us shortly, but
Okay.
I will let her know.
And then the next thing under old business was just to ask if we can have an update on reimbursement to districts for COVID-19 related expenditures, contact tracing and COVID testing, which we are still very much in having to do. And the federal government at this point is not providing tests to school districts unless something changes. The White House said, I was in a meeting this week and Dr. Jha said that we're expecting another COVID surge in the upcoming weeks. We'll know for sure if it's a full-on surge in the next 4 to 5 weeks is what he shared. And so, and if you've watched the news, we've had 50 or so school districts in Kentucky having to close related to illness, a lot of flu A and some COVID. But anyway, this is a real important issue for school districts. And I just wonder, for school nurses, but for the families that our nursing TAC represents as well. And I just want to know if there's an update on this. I think at the last meeting, it was said that this was something that DMS was looking into and that they would get back to us on what the updates were.
Do you know who gave that and said that they would get back to you? Which staff member?
It was, do you remember by chance, Lisa? It's the, and I'm terrible with names, so forgive me, but he took Lee Geis's position.
From DMS.
Yeah.
Yes,
Justin Derringer?
that's it.
Yes, yes.
Okay. I don't believe he's on. Let me look. He may have had a conflict. I can certainly ask him
Okay,
and forward the information to you through email.
it's good.
Erica Davis, are you on? Would you be able to give any information?
Yes, I am on. Eva, what was the question specifically that you're needing?
So COVID related expenses aren't
Mhm.
currently included in the tag as other things are. So school nurses haven't been able to bill for contact tracing, for COVID testing, and those sorts of things. And Mr. Derringer said at the last meeting that was something that was being looked into because federally it's an allowable expense for Medicaid. And so we're doing at least in our county, we're doing the bulk of testing that's even available. And I just want to know where we stand because after January, we won't have that resource of free test available from the federal government. And as it stands, it's not been something we can reimburse for contact tracing at all, which takes a lot of nurse time. And
So we will be adding the COVID testing and COVID vaccinations to the tag. I am not sure still about contact tracing. And I would have to get with leadership for their decision on that.
okay. I would just say, so Jen's asking, are we still contact tracing? Yes, we are absolutely doing a lot of contact tracing. What the CDC recommends for school is contact tracing for those school-related cases. So in schools, we don't do contact tracing for cases that the parent reports and they may have gotten it someplace else. But when we have a case in a classroom, we are contact tracing, and I don't know if that is across the whole state, but it's something that CMS on a federal level allows to be included in school-based Medicaid billing.
Do we get any reimbursement or do you get any reimbursement for RSV testing?
We haven't been doing RSV testing. It's not currently in the tag either. It's something that we're exploring doing, and federally they're including schools to be doing flu testing as well, which we're exploring, looking into. And if I haven't looked, I don't remember, but it seems like flu tests are something that's currently included in the tag.
Because the RSV and the flu is what's closing the schools right now.
Right now, until this next surge comes. That's correct. Yep.
Has anyone talked to public health
I'm sorry, you broke up
contact
there.
tracing? I'm sorry, I'm just thinking public health was in charge of contact tracing, and they kind of know all about that. So I'm wondering if anyone has talked to public health.
Oh yeah, Judy, these guidelines for contact tracing came from public health.
Okay.
And at least here in Jefferson County, I still have bi-weekly meetings with our health department. They still have a school team that helps us follow up on school cases. But we have to collect all this information. Every school district in Kentucky by law is required to report any communicable disease to their local health department. So that still includes COVID, that includes flu, includes RSV. Those are reportable diseases. So it's challenging to not be reimbursed for some of the work that's associated with us following the law as it's written.
Okay, thank you.
And I have a question, and this is just so I can better understand, because I do not know how people are reimbursed for contact tracing. It's not something that I do in my line of work. But when you get reimbursed, is that like something that's just submitted and there's a flat rate? Or do you bill hourly for working on contact tracing? Like, how is that submitted to Medicaid? Or how are those bills paid?
So I can't answer that, Jen, because we're not able to do it. We're not able to get reimbursed for it. So we're not submitting claims for it, but we do contact tracing at the level of each individual student. So when a student in a classroom is a close contact to a case of COVID, the nurse does outreach to the family. So first the nurse pulls in the student, they do an assessment to see if they are symptomatic, and then they reach out to the family with guidance on what their next steps are. We assess for underlying chronic illnesses because of those kids that have increased risk for poor outcomes for COVID. And so then that information is communicated to families. And then the CDC has a protocol for what close contacts should be doing in a school setting. So we might do daily testing for those students, and then we educate the parents on the need to wear masks for 10 days and so on. But I don't know, it would be billed at the individual level. Health departments have been able to bill for it in Kentucky and bill through Medicaid, but we haven't in school-based billing. So Judy, you may be able to answer that better.
Right. Well, I was just going to say that we've done it sort of as a public health issue. And public health is in charge of the health departments doing the contact tracing. And it does take an awful lot of time per patient. But that's why I was a little confused, because outside of the public health realm with their local health departments, it's not really being paid for by Medicaid. I don't know if other insurance companies pay for it for their kids or not.
No, it's not right now, Judy, but on a federal level, federal Medicaid says school-based Medicaid can bill for contact tracing. We just haven't done that in Kentucky.
Okay. So that was my question. So I don't think it's happening at all. And would probably have to be under the we'd have to talk to public health about that kind of stuff.
And I guess, can you also hear me?
Yeah.
Okay. I guess my other question, so, and like I said, I don't know a ton about what's going on in the school, but I do recognize what Lisa mentioned with our current situation. I think it's important that we also look at being able to like flu test and RSV test in schools. So I don't know if that's something that would be initiated within the schools, or if there's a DMS aspect to that it needs to be something that's guaranteed, like for sure reimbursable for the school system, because I don't know the current data on COVID, but I mean, there's like exponential, increase in those cases as opposed to any COVID related cases. Just across the general population, like even outside of the school. So I can only imagine when you're focused on kids who spread stuff probably quicker, easier than everybody else.
Well,
Those numbers.
Yeah, to your point, it could make a big difference with schools not having to close, which very much impacts social determinants of health. When the schools close, then that puts those kids behind academically. So Jen, for us in Jefferson County, which of course we're a lot bigger than everybody else, but when we got our CLIA waiver to be able to do COVID testing, we went ahead and included rapid flu test on that. Our challenge has been, like, I have to convince our administration that we want to start purchasing flu tests. And the challenge for us is how many flu tests, because we've got 100,000 students basically and 16,000 employees. And so we have to make it accessible across the whole district, but we're still doing it. We're in the process of trying to get our hands on those because our school nurses, we need to be able to figure out whether we're dealing with a COVID or flu or RSV outbreak in a school so we can respond. A lot of school districts, there are school districts who are doing flu testing right now. They're nurse practitioners. They have nurse practitioners in the schools that are doing it. So I think it's something that as more districts do it, it could be a powerful tool at helping to keep these illnesses at bay and keep kids in school, along
So
with
is this-
vaccination. Yeah.
And my other question is this only something reimbursable for when it's performed on those kids who are Medicaid kids, or is this something that is reimbursable for every student because it's being done at a school?
If we bill it through expanded Medicaid billing, then we would just bill those. It has to be accessible to everybody, but the billing would happen through Medicaid for those Medicaid eligible students.
Okay. So, okay.
Lisa, you want me to go on? Okay. So the next question that's come up, and we got an email about it today, but so we're doing a community of practice with nurses across the state to try and educate them on expanded billing in schools. And so one of the questions that have come up from the nurse practitioners who are taking place in that is their reimbursement for preventive health exams. So these nurse practitioners are doing physicals, and their reimbursement rates for those visits are $6, $7, $10. And they're also doing visits for students. So it's costing them $6 to $7 per test. So if they do a flu test, they're ending up paying that amount for the flu test. And then they're doing the office visit, and they may do a strep test as well, which is a cost for them as well. And their reimbursement rate is again about $7 for nurse practitioners. So they're getting lower reimbursement rate for the nurse practitioners than they are for RN visits in their schools. And so we got a message today that says a registered nurse is not a recognized provider type by Kentucky Medicaid. I think there should be a statement in there that says unless they've done well child training through the local health department, because health departments do billing for RNs. So there's not a fee schedule or billing manual for an RN. If you're referring to advanced practice nurses, they're paid 75% of the physician fee schedule for codes within their scope of practice. Well, $6 to $7 is not 75% of a physician's reimbursement for a preventive health exam. And so some of the feedback that we've gotten regarding this is that, well, there hasn't been a cost settlement completed yet, but it's still, the question is, why is the reimbursement so low for nurse practitioners that are providing services in the schools compared to nurse practitioners who are practicing outside of schools?
It doesn't make any sense.
I mean, is there a reason that it's not commensurate with the fee schedule that nurse practitioners are following in a clinic setting for those same?
It should
CPT
be
codes?
exactly the same fee schedule. So it doesn't make any sense to me either.
So I don't know who to ask. What are next steps? Is this something that is a question that has to go to the MAC, or they who has said?
Probably so. But it doesn't make any sense. I mean, they're working in the school system, but it's still essentially a clinic, right?
Yes. Many of the nurse practitioners are credentialed through health insurance, and they're not billing health insurance for students because they can't, but they are seeing staff, and they're billing health insurance for staff when they come in and do those flu and strep tests and getting reimbursed at Anthem's rate or, the fee schedule, but they're not through school-based Medicaid.
Eva, I'm not sure the reason for that either, but I would like to look into it further. Is it possible that we could maybe have a call a little bit later, and that way I can pull some data and look at what some of those claims have been for the amount, and just look at overall in the state what
Yeah.
we have been reimbursing?
I'm great with that. And if anybody else wants to be on that, we can just tell me what the rules are for us to do that. But I'll do whatever you all tell me to. I'm glad to, Erica.
Yeah, it seems like we only have the one fee schedule, so I'm wondering what the codes are being, if it's a flu shot code, like that's, that sounds like you would get $6 to $7 for that visit. Versus an actual preventive health visit where, you would get, I don't know, $40 for that visit.
Could it be the system is only picking up because the way the school-based Medicaid is set up, they're not able, they're choosing their office visit, but they're not able to select multiple CPT codes that are associated with that. They've also shared that as well. Like if they do a visit that has flu and strep, they don't have a way to enter both of those CPT codes, and that doesn't make sense either.
You may have figured out what's up.
But it still should take the overall code.
Yeah, you should be able to bill the visit plus
Visit.
whatever test you're doing. Plus a shot, if you give them a shot.
Right.
Mhm.
Well, I'm glad to connect with them and get some more specifics. And then Erica, if we need to, we can have a conversation about it. I can share that with you, or I can email that to you.
Hi, this is Erin. I wanted to cut in really quick. I do apologize for being late. I do not believe you can have private meetings to discuss TAC issues, but I will clarify that with Veronica Judy Cecil. But anything that's brought to the open meetings, because we're an open meeting request state, we may have to pull that data and bring it back to the next meeting, but I will clarify that just to make sure. I just don't want to get anybody in trouble.
But I could get some specifics and email those to the group, correct?
Yes, you can send some specifics in an email for us to look into, kind of as a TAC follow-up. But you're not supposed to have any kind of like private, they consider them private and open meetings. And so I just wanted to make sure that we don't go against
What's
any
good you showed up because we
laws and regulations.
That's understood, and that would be really helpful. I think that's what the private meeting would have been for, was just to get specifics. So if Eva's able to provide those through email, that works perfectly.
Yes. Sorry about that, Erica. I didn't mean to cut you off.
Oh, no, you're fine.
Okay, well, then the next thing under new business, so blood glucose testing, lead screening, and RSV testing are not in the TAG. And so I'm wondering if those are things that can be added, because those are things that we need to be doing in the schools. And that goes back to the conversation we were having earlier about RSV. And then also reimbursement for RNs to do dental screenings is not included as reimbursable in the TAG. And in Kentucky, we're required, it's required for 5 to 6 year olds to have a dental screening or exam at age 5 to 6. And per the Board of Nursing, registered nurses can do those exams. And so, but it's not included as a reimbursable, service in the TAG. Schools across the state right now, a very low percentage of children are having the dental screenings done. And so this could be something that could help incentivize schools to do the screenings so they can get them referred for care, which could help with our longstanding problem in Kentucky of leading the nation with people who do not have teeth. I'm from West Virginia originally, so this is a constant back and forth between my sister and I as to who is number one. So anyway, I'm just throwing those out there.
Oh, I was just going to say, I know I thought the dental screening had to be done by a dentist. Because we were told as pediatricians, we couldn't do them, just like I mean, you can do them, but it doesn't count. Just like the eye exams. So
No.
even though we check the vision and everything in the office, it doesn't count. They need to go to an optometrist.
Dental screenings can be done by a physician, a nurse practitioner, or a registered nurse, in addition to a dentist. There's not, the question was about registered nurses, but it's a question that went to the Board of Nursing as to whether that was in their scope of practice, and it is in their scope of practice to do the screening. But yeah, all those provider types are able to do the dental screening. Now, Dr. Thoreau, there is Head Start programs. Those children have to have a dental exam each year by a dentist, but that's only for Head Start, children in Head Start preschool programs.
Maybe that's where I'm getting mixed up.
It probably is, because the screening that's required for school can be done by a number of providers.
Okay. Thank you.
Well, I never knew nurses could do dental screening, so I just learned something.
Yeah, they can, if they go through special training, Lisa, they can put sealants on too.
Get out, really? Okay.
Teeth kind of gross me out. I don't think I'd want to do that.
Okay, well, I guess
Just to,
move on.
to
Okay, go
educate
ahead.
me, Eva, or when
Yep.
we say adding to the tag, you're talking to adding to the charge, adding to the,
Adding to the technical assistance guide, so
Okay,
there's
okay.
there's a document that Medicaid and Department of Education do that they make available to schools to tell them how to provide services.
okay.
To respond to that, I don't have the answers of how much of that will be added to the tag, because that would require us approving, accepting those claims. So I will get that information and provide that back as well.
Thanks, Erica. And I just shared a link to the document for school, the 5 to 6 year old dental screenings, and it lists on there that dentist, dental hygienist, physician's assistant, registered nurse, APRN, and physician can do those exams. And KDE still has on there the words "with training" behind registered nurse, but we've got a document from the Board of Nursing that says it's within they're trained to do it in school, and it's within their scope of practice to do them.
Sounds good. Thank you.
And Judy, I didn't realize that either, so I'm glad that they brought that up, but I wonder if it's a matter of who can fill out that form versus who can bill. I wonder if all of those people can bill outside of Medicaid, or can they bill private insurance for that? All of those providers, or is that maybe, you know what I'm saying? I'm just saying that can lead to a misunderstanding where if a kid isn't a Medicaid recipient, you know, is that billable by an RN to submit, or is that billable by an APRN? Or is it just a matter of, yes, they're allowed to fill out that form, but as far as billable services, you
Right.
see what I'm saying? I don't know if I'm being clear or
No,
what I'm
oh, you
asking.
are. Yeah, I wonder. I mean, in my head, it's all part of the general, you know, preventative screening. So physicians wouldn't bill separately for that.
No,
But
most
if you're
of the
like
time-
doing a clinic and you're, you know, that's what you're doing, like when you do scoliosis screens or whatever, then it's different.
Yeah, so I will say, when we have an outside provider do them, and if it's usually tied to their physical exam, and then they fill out this form for the school.
Yeah,
because
for the
the
school.
form is what the school has.
Yeah.
We do dental screenings, and a lot of the school nurses, the schools around the state, we're required to have screening programs for students. And so that includes hearing and vision. And then for other health and dental screenings is part of that as well. So when we do our hearing and vision screenings in schools, we also look for all those 5 to 6-year-olds that have not had dental screenings, and then we'll have nurses do their dental screenings. At least that's the model we're moving to now that we have school nurses. So there are other school districts in the state that do that. But it's an individual assessment on a student,
Right.
because you have to do all those things that are included on the form.
Yep.
So anyway. The last bullet is a question that I had really about, so several of the MCOs have presented on, how they have access to their patients for incentives and just around their enrollment process and so on and so forth. And so I really have a question, because this has just been such an issue in my district, and I know Bowling Green, Fayette County, there's other districts around the state that have similar concerns, because they have a high percentage of families that are immigrants and refugees coming into their counties. And so each of the MCOs, when they sign their contracts, included in the contracts are a non-discrimination clause. Yet we don't have materials in any language outside of Spanish. We don't have ways for families to access incentives that are easily accessible for those who are living in poverty or who speak another language. And so I guess it's just a question I have for us to discuss as a group, to talk about what is the purpose, what are those non-discrimination clauses there? How are those, what's the quality assurance, I guess, related to non-discrimination for entities that are providing services in Kentucky?
Hey, good
Great
afternoon.
question.
This is Shannon. This is Shannon Jones from WellCare, Kentucky. Can you guys hear me?
Yes.
Yep.
Yeah, so to speak a little bit about that from my perspective, I'm the Senior Director for Medical Management overseeing case management. And so we have identified it, as you said, especially in the Bowling Green area with the refugee population and centers. So I actually have one dedicated FTE that we assign to that population. And so we have a translation line that is utilized. We also assist the members by going to PCP visits. And as far as the materials, we have those available through translation. We can also get those printed out, but primarily what we found is that it works better to have that case manager in the interaction. And so even if, let's say, the member graduates from our program, right? If we see the member come back through, we continue to send that member to the same case manager to ensure the continuity of care, because they've already established a relationship. Sometimes there's trust issues and things like that. And my FTE is actually from that Bowling Green area, so she's able to attend visits, anything that the member has, and she translates into, here are the value added benefits. These are the things we can do for you, such as discharge meals. If there's an inpatient visit, she goes ahead and sets those up. We do look at, the preferences around specific populations to make sure that anything that we are providing is within the scope of what they need. Does that help from a perspective from WellCare?
Yeah, it does. I just, so is the process still for a family to get a case manager? Do they still have to call that main number and request a case manager, or is there a different process? And then if somebody does call, are they how are they routed to determine what
Yeah.
language they speak? Do you see what I'm asking? What language they
Yeah,
speak and how they would
absolutely.
get to the right person? Like here in our school district, we have over 160 different languages spoken. So it's a really widespread need.
Right, and we've seen it continuing to grow as well. And Kendra, who is the FTE that oversees the population, is really good to work with other case managers in looking at this may need to grow, right? So we have many forms ways that you can come into case management. Absolutely, they can call the number on their back of their card. So in our system, when we get the information from the state, that language is brought over as well.
Okay.
So we look at that, and then our team is trained that, you know, when they see that, we go ahead before we do an outreach, have the translation line on and so forth. We take member referrals, we take physician referrals, we have referrals from homeless shelters, DMEs, so a wide variety, including and not limited to politicians. So anyone in need of case management, we're growing in WellCare a homeless outreach program. And one of the things that we're doing in 23 is doing a widespread across the state. One of the issues that we find is that, you know, due to HIPAA, it's very difficult for us to engage in some of the centers and things like that. So we often leave cards to have the people call back in for us. I know from a community engagement, there's also a lot of opportunity there where they go into the areas, the school districts and things like that and set up. And of course we partner, and if there are referrals, if they see kids through the school system that need referrals, they send those as well. And then also we partner with the schools to, you know, they're generally, especially for a complex peds population that we have, the schools is generally the best source of truth. We know about the IEPs and things of that nature. But, you know, you're right, it's very difficult sometimes. And, you know, that's why we have one assigned case manager, because something that would take 25 minutes for an English speaking member sometimes takes 3 hours. And so we recognize that early on, and we've had this specialized approach for several years now.
Thanks, Shannon.
It can be really difficult to find translators too. Really, I mean, hospitals, from a hospital perspective, we struggle to find translators for people, even with video translator availability. I can't imagine. It just must be very difficult.
We haven't found, you know, any issues. I think several years ago, there was one specific language that our vendor struggled with a little bit, but to my knowledge, we have not had any individual that we could not secure a translator for.
Well,
again, we use a vendor, which helps out a lot.
That's good. I'm glad to hear that, at least.
Yeah, and this is Stephanie with Anthem. We're pretty much along the same lines there. We have an interpreter, the translation service, the vendor and the outside, and then we have all our different materials in, you know, multiple languages. I don't know the exact number off the top of my head. And then we have case management, and then we have our social determinants of health team that goes out into the community so they can contact and really try to engage those members, you know, in with the right community, business partners, and then as well as our public health consultants. So we have a few different teams outside of case management that we can utilize to, depending on the members' needs, and try to get them engaged with the right resources. So we are trying to work on that as well.
So I guess my
And-
question, oh, go ahead.
I was just going to say, this is Samantha Harrison with Humana Healthy Horizons in Kentucky. We also have similar programs and the language assistance services that's free of charge that's available for all those languages as well. I don't want to keep you from proceeding, but I just wanted to join in the party to detail our discrimination pieces. It's all in our enrollee handbook as well, along with that telephone number that can aid those members if they need it.
And this is Anna from Passport Health. I just want to add, we have very similar processes as well with the language assistant line. All of our letters include a tagline with probably, I think, maybe 20 different languages on there in the native language if the member needs information in their native language. So we follow suit as the other MCOs do.
United Healthcare. I would just echo what everyone else has said. We have very similar processes. We have a wonderful interpreter and translation line, and we have had many different dialects and different languages our members speak, and we have been successful with even getting I guess the less common dialects. We've gotten several different interpreters for our members. We had Kenya-Rwandan, and I think there was one from Guatemala that it was a specific dialect from Guatemala that we had to work with a translation line vendor to find somebody. So we have extensive ways to go about meeting our members' needs when it comes to translation or interpretation. And we can get materials translated into, I mean, there's a long list of how many different languages we can translate it into. So the other piece that I wanted to add is that when we enroll someone with United Healthcare, we do a welcome call. And at that point in time, when we reach a member and identify that they are non-English speaking, we are able to get interpretation services on the line. We capture that information in our clinical systems or in our member systems so that we have that information available for anyone who then goes to reach out to our members. And we also try to identify if there are any gaps, any needs, any social determinant of health needs when we do reach the members with the translator on the interpreter on the phone. So again, we try very hard to make sure that we can identify needs upfront at the very beginning of enrollment, and identify people for additional needs and services and care coordination if necessary. And that we also capture that language information so that future information can then be translated correctly into the member's preferred language.
Thanks, you all. So 2 more questions. One is for the MCOs and the other is for DMS. And for the MCOs, so if a nurse or a nurse practitioner had a patient that they felt needed additional support and they were non-English speaking, they could refer that patient for case management services, and somebody would do outreach to the family in the language that they speak at home. So that's my question to you all. And then for DMS, are there any kind of metrics that are measured based on race for pediatric outcomes for children in Kentucky? Not race, but race and ethnicity both, that the MCOs report on? Mm-hmm.
From a case management perspective, again, this is Shannon with WellCare. Absolutely, and we've had that scenario happen several times, not just from physicians, but neighbors, other things, where we do make sure that we are set up with a translation line to ensure that the communication is thorough. We're able to do the assessment and really make sure that we identify the needs and the goals of the member.
And for DMS, as far as people report their ethnicity and the race, we can break things down and look at outcomes based on that demographic. So, for example, kids with type 2 diabetes, we can give you a number on that for, for race and ethnicity. Now, anywhere between, gosh, 12 and 20% of the time that race data is unknown because it's an optional box to check, but we know about it 80% of the time.
Gotcha. Thank you, Dr. Thoreau. So do the managed care organizations, Dr. Thoreau, do they have any of the measures that they report on to DMS? Do they have to report anything around race or ethnicity? Like, well, you know, whatever metrics are chosen for the state. So what, you know, whether it was on their report, on the reports that are done, preventive health exams, are those just reported in general, or are they presented by, you know, age and race and ethnicity? And if they're not, is that something that could be required?
I don't know what, I mean, there's so many reports. I don't know the specifics of the reports, but that is information that we have. And the MCOs have the same information on race and ethnicity.
Hey, this is Jennifer Knockrider with Aetna. I think what we're getting at really is health equity. And it's a huge area of focus within each MCO. I think we're just on the cusp of sort of formalizing what that looks like for reporting and coordination of services across MCOs and with DMS. But I think it's a timely topic and one that's really important, which is, are we looking at the more marginalized and vulnerable populations and comparing those to other groups who may have better access to services? So I think it's the right conversation at the right time. And maybe we don't have all of the supports in place currently, but I can guarantee that these are a topic of conversation within each MCO and among DMS as well, from a general equity perspective.
Thank you all. Thanks for what you shared and for the feedback. Yeah, I think you're right. It's a very important area. And I appreciate knowing about the case management as well, because that's something that can be of use for nurses everywhere, no matter what setting, to know that they can help facilitate getting support for a family.
Agree.
Yeah, this is Stephanie with Anthony now. Just add to that, you know, most members just, you know, we're really, you know, trying to work on getting the word out that we do more than just, you know, provide services and pay bills. There are a lot of different, you know, they're all called something a little different at each MCO, but, you know, there are healthy rewards where they get so much money for doing preventative exams. There's value-added benefits where they might get a free stroller or, you know, books for babies or free diapers. So yes, if you know, they can get in contact with case management and get, you know, so that they can, you know, be aware of all the different resources. Again, we, you know, try to do different text, you know, all kinds of different campaigns, calling, texting, emailing. We need to try to get that information out to our members. But it certainly would be great if other folks could advocate that, you know, for us as well when they're in touch with our members, because each MCO has something similar to that. So there's a lot of great extra benefits, if you will, that each of us have that, you know, sometimes they you know, don't take advantage of or aren't aware of.
Yeah, thanks you all. Lisa, that was my last bullet.
No, they were great questions. They were great questions. It's encouraging to hear that everyone is doing so much looking at health equity. I'm pleased. I was pleased to hear that. So thank you all very much for all your input. We appreciate that. Do you have anything for us out there other than what you've already added to the conversation, of course? Any questions or anything anybody'd like to add?
Stephanie, if I could just clarify on the old business on that second, if you scroll up just a little bit on the second bullet with all those kind of sub bullets under them, are those under the old business up a little further? I thought you said that that was for DMS, but I just wanted to make sure and clarify.
Yes,
Yeah.
those were data requests. I'm sorry.
No, it's okay. Ava,
Okay.
I'm sorry. I was just gonna let Stephanie know this was the data request that the TAC made to DMS, that DMS fulfilled. We do have one more data request that is being reviewed. They came into two separate data requests. And so as soon as that other data request is fulfilled and reviewed, I will get that out to the TAC as well.
Okay, thanks, Erin. It looked that way, but there were a couple things that said MCO, so I just wanted to clarify, make sure that if I need to.
Yeah, most of that stuff we were able to pull out of our database from the reports that you guys send to us. And so if there's ever a need that the TAC makes a data request that I need from you guys directly, I'll make sure to get it to you.
Okay, thank you, appreciate it.
Perfect, thank you. Anything else? Okay. Dr. Stone, as always, thank you. You had a lot of great questions. Spawned a lot of good conversation. Very appreciated. Let's see, our next meeting. And we have, when is the MAC? I just saw my invitation from them today come across.
The next MAC is January 26th.
Okay. So hopefully we'll get an answer from them about our little question that's hanging out there.
I
And
believe
then
the
we need,
recommendations are due on the 3rd. We try to have those out prior to the 45-day, but that 45th day is January 3rd. So you should have an email that will come with an official response from DMS.
oh, okay.
No later, hopefully no later than the 3rd.
Okay, all right. And then we meet again in February.
Yes, ma'am. And Kelly, who introduced herself at the beginning of the meeting, if you guys don't mind, just start copying her on emails.
Okay.
She's going to be my new partner in crime. And then in March, when I go on maternity leave, she'll be your main contact until I return.
Excellent. Okay. All right. Well, with all of that, I guess I can wish everyone a happy holidays, Merry Christmas, and thank you, everybody. Can we have a motion to adjourn?
So move.
Can I have a second?
I'll second. This is Jennifer. Let me turn my.
Okay.
Yeah, turn your camera on.
There you go. A second.
Thank you, Jennifer.
All right.
You're so
All right,
welcome.
everybody. Thank you.
Have a
Enjoy
great
your
day.
holidays.
You too. Bye,
Thank you
everybody.
for everything you do. We appreciate you being here.
Everybody have a happy holidays.
Thank you. Bye-bye.